Welcome to TLDR Neuropsychology, where we cover various topics related to the practice of clinical neuropsychology. Today we're continuing our preparation related to the written component of the Clinical Neuropsychology Board Examination. And today's topic is going to be a brief overview of neurological diagnostic tools. So today we're going to cover the neurological exam, structural neural imaging studies, functional neuroimaging studies, electrophysiological studies, and invasive examination procedures. Typically, these examinations and procedures are ordered and conducted by various medical staff, including physicians, particularly neurologists, as well as technicians who manage the specific technologies. So we're going to start with the neurological exam. Understanding the neurological exam is relevant to neuropsychological practice in that it's often a component of medical documents that we end up reviewing. So it's important to have this basic understanding of how these procedures work and their results so that we can utilize this information more effectively in interpretation of our neuropsychological data. The neurological exam is a physical evaluation conducted by medical staff, and it includes evaluation of cranial nerve functioning, sensory motor systems, deep tendon reflexes, gait coordination and cerebellar functioning, as well as general mental status. The cranial nerves are 12 paired sets of nerves emerging from the brainstem. And remember that nerves are bundles of axons that travel outside of the central nervous system, the central nervous system being the brain and spinal cord. The cranial nerves are numbered using Roman numerals, and the ordering of the numbers is based on their position within the brain. Superior nerves, or ones that are higher up on the brainstem, have a lower number, and as you descend down the brainstem, the cranial nerves will have a much higher number. And you can group the cranial nerves based on the function that they're associated with. So there's 3 cranial nerves that are associated exclusively with sensory information. There's 5 that are associated exclusively with motor functioning, and there's 4 that have both motor and sensory components. And nerves 9 and 10 are associated with the gag reflex, and the gag reflex is used to assess their functioning. A loss of functioning in these nerves is considered cranial nerve palsy, and this can result in disruption to either sensory or motor functioning, and it depends on the specific nerves involved. So the first cranial nerve we're going to discuss is the olfactory nerve, and it projects from the olfactory regions of the cortex to the midbrain. And this is tested by blocking off one nostril at a time and asking patients to identify specific strong fragrances. Things like coffee, peppermint, peanut butter, whatever it may be. When there's a loss of ability to detect smells, it's considered anosmia or smell blindness. And anosmia can be caused by masses in the brain, so things like tumors or abscesses, cranial trauma, and this is particularly when the damage is done to the orbital frontal regions or around the areas that separate the nasal cavity from the brain. Viral infections can also impact olfactory functioning by disrupting the olfactory neural epithelium, which is specialized tissue within the nasal cavity that can facilitate our sense of smell. The next cranial nerve we'll discuss is the optic nerve, or cranial nerve 2. And this is a sensory nerve involved in vision, and it projects from the retina of the eye to the midbrain. And this is assessed by having patients look into the examiner's eye and asking them to identify finger motion in their peripheral vision. So it's important to understand the pathway that the optic nerve travels, because damage in different parts of that pathway can create different types of pathology. So the optic nerve travels from the retina to what's called the optic chiasm. And the chiasm allows information from each eye to cross over to the opposite brain hemisphere. So it's the temporal fields of our vision, or the ones that are more peripheral on our heads, those are the ones that cross over. When these visual pathways are damaged, there are a few important issues that can develop. So one is called hemianopsia, which is loss of half of your field of vision. And this can either be bitemporal hemianopsia, which is loss of vision in those temporal visual hemifields. And that's related to damage in that optic chiasm where the neurons that carry that information cross over to the other parts of the brain, as well as homonymous hemianopsia, which is loss of half of the contralateral hemifield, and that's caused by postchiasmic lesions. So contralateral would be on the side opposite of where the damage occurred, whereas ipsilateral would be on the same side as where the damage occurred. If the injury occurs before the optic chiasm, it can cause monocular vision, which is loss of vision from one eye. And if the damage occurs after the optic chiasm in the optic radiations, then you can lose vision in certain quadrants of your vision, and that's called quadrantanopsia. So you can have homonymous superior quadrantanopsia, which is loss of vision in a superior quadrant to the contralateral side of an injury, or you can have homonymous inferior quadrantanopsia, which is loss of vision in an inferior quadrant of the contralateral side of the injury. And if you look at the graphic on the lower right, it has a depiction of where different lesions can occur and then how that can affect people's visual fields. So you can see if the damage occurs at 2, where the optic chiasm crosses over, that it will block out those temporal hemifields. Whereas if the damage occurs at a place like number 5, then you're experiencing that inferior quadrantanopsia. The next cranial nerve we'll discuss is the ocular motor nerve, or cranial nerve 3. And this is a motor exclusive nerve that originates in the midbrain, and it's responsible for activation of most of the extraocular muscles, with the exception of the oblique and lateral rectus muscles. So this controls movement of the eye towards the nose and movement of the eye up and down. And it's assessed by observing someone's eye movements, whether you're asking them to move their eye to look at specific things, or just the natural saccadic eye movements that someone will make as they're scanning a scene. And it's also assessed by evaluating whether someone's pupil constricts or dilates in response to a light being shone in the eye. So a couple of conditions that can occur when there's injury to cranial nerve 3 is a blown pupil, which makes the pupil fixed and dilated, so it gets bigger, and it's often following some kind of aneurysm or uncal herniation. People can also experience a pinpoint pupil, which is when there's that persistent constriction of the pupil, which makes it look like a pinpoint, and that can indicate either dysfunction in the pons or drug overdose, particularly with opiate drugs. The next cranial nerves we're going to talk about we'll lump together. So one is the trochlear nerve, or cranial nerve 4, and the next is the abducens nerve, or cranial nerve 6. So these are both motor nerves, and they innervate those other eye muscles that are responsible for eye movement. So cranial nerve 4 originates in the midbrain, and it projects to the superior oblique muscle of the eye. And cranial nerve 6 originates in the pons and projects to the lateral rectus muscle of the eye. And these are assessed by observing someone's vertical and lateral eye movements. When there's dysfunction in these nerves, you can end up with double vision or diplopia. And this can cause a doubling of vision either horizontally, where you have 2 of the same image side by side, vertically, where the image is doubled with one below and one above, or oblique or in a diagonal direction, where you get both the horizontal and the vertical doubling at the same time. When it's vertical, that's a common sign for disruption of cranial nerve 4 functioning, and it can be related to things like cerebellar tumors or traumatic brain injury. And when diplopia occurs horizontally, that indicates disruption of cranial nerve 6, and it's often related to increased intracranial pressure within the central nervous system. The next cranial nerve we'll discuss is the trigeminal nerve, or cranial nerve 5, and this is a mixed functioning nerve that carries both sensory and motor information, and it originates in the pons and innervates the upper, middle, and lower parts of the face. So the trigeminal nerve has 3 branches that carry sensory information from facial, nasal sinus, mouth, and the anterior 2/3 of our tongue. And these branches are the ophthalmic branch, the maxillary branch, and the mandibular branch. And if you look to the image on the right, you can see what parts of the face each branch covers. So the trigeminal nerve also controls the muscles necessary for chewing food. And you can assess it by evaluating facial sensation, corneal reflexes, as well as jaw jerk reflexes. When there's dysfunction of the trigeminal nerve, it can cause a severe and chronic pain condition called trigeminal neuralgia. And many people who experience this condition end up taking their own lives. The next cranial nerve we'll discuss is the facial nerve, or cranial nerve 7. And this is another mixed function nerve that originates in the lower pons and upper medulla, and this controls the facial muscles we use to make expressions, tears, salivation, and taste from the anterior 2/3 of the tongue, as well as just general somatosensation in the face. And this is often assessed by looking for asymmetry when someone's making spontaneous facial expressions. So does one side of their smile go higher than the other side? Does half of their face droop? Those kinds of things. So following a stroke, if there is notable facial droop in the lower face and mouth, but the forehead is spared, that typically indicates disruption to the facial nerve. The next cranial nerve we're going to talk about is the vestibulocochlear nerve, or cranial nerve 8. And this is a sensory nerve responsible for auditory and vestibular functions, and it carries information from the auditory canal to the pontomedullary junction. And one of the tests of the vestibulocochlear nerve is the RIN test. And this is a way of testing auditory functioning by placing a vibrating tuning fork either on the outside of the pinna of the ear, on the forehead, or on the mastoid. And what you're testing with these different placements is air conduction and bone conduction, respectively. With normal hearing, air conduction will be greater than bone conduction. And if there's some kind of sensory neuronal hearing loss, which is the result of damage to structures in the inner ear, or cranial nerve 8, air conduction continues to be better than bone conduction, but you tend to have sound lateralizing more to the normal ear. There's another condition called conductive hearing loss, and that's hearing loss as a result of auditory canal or middle ear abnormalities. And that can be detected when bone conduction hearing is actually superior to air conduction hearing. To test the vestibular component of cranial nerve 8, doctors will administer the Dix-Hallpike maneuver. And this can help differentiate between peripheral and central causes of things like vertigo. So for this maneuver, the patient is seated, the examiner supports their head at a particular angle, and then quickly lowers the patient to their back while observing their reaction. And what they're looking for is nystagmus, which is rapid, involuntary, and repetitive movements of the eyes, and that would indicate dysfunction of cranial nerve 8. And this can occur either in the horizontal plane, the vertical plane, or the combination of two, which causes a rotary or oblique nystagmus. The next cranial nerve we'll discuss is the glossopharyngeal nerve, or cranial nerve 9, and this is a mixed functioning nerve involved in sensation, including things like taste, touch, pain, and temperature from the posterior third of the tongue, the palate, as well as the pharynx. And it also has a motor component that's involved in swallowing. And this nerve originates in the medulla and projects to the pharynx, middle ear, and posterior tongue. So this is usually assessed by inducing the gag reflex. Typically, you'll reach a probe in and poke at the uvula, which is the dangly part in the back of someone's throat. And you're looking to see if they actually have a gag reflex and if the uvula retracts evenly or if it retracts more to one side than the other. Dysfunction of cranial nerve 9 can cause dysphagia, which is difficulty swallowing. Difficulty swallowing or dysphagia can be caused by damage to both cranial nerve 9 and cranial nerve 10. So speaking of cranial nerve 10, this is the vagus nerve, and it's a mixed functioning nerve that originates in the medulla and innervates the heart, lungs, digestive tract, pharynx, upper esophagus, and larynx. And it's involved in parasympathetic functioning of our heart, lungs, and digestive tract, the swallowing and gag reflex, as well as speech by controlling the voice box. And this is usually assessed in conjunction with cranial nerve 9 when testing the gag reflex. The vagal nerve is used as a pathway for treating certain kinds of epilepsy as well as treatment-resistant depression by delivering electrical impulses to this vagal nerve, and that's called vagal nerve stimulation. The next cranial nerve we'll discuss is the spinal accessory nerve, and this is a motor nerve which originates in the upper spinal cord and projects to the sternocleidomastoid and trapezius muscles, and this one is responsible for our ability to shrug our shoulders and turn our head. It's assessed by having the patients perform those movements with and without resistance. And dysfunction is indicated by unilateral weakness, which can be demonstrated by either shrug asymmetry, so one shoulder coming up higher than the other, or more difficulty turning their head one way than the other way. The last cranial nerve is the hypoglossal nerve, or cranial nerve 12, and this is a motor nerve that originates in the medulla and projects to the tongue muscles, and it's assessed by having patients stick out their tongue. If there's damage to cranial nerve 12, you'll see weakness on the ipsilateral side of the tongue, so the same side that the damage is occurring. And the tongue will deviate to the side where the injury is. So if you look at the image to the right, you can see clearly on the left side of this person's tongue that there's a deviation toward that side. So that would indicate that there's damage to the left projection of cranial nerve 12. You can also assess the hypoglossal nerve by asking patients to repeat challenging phrases, things like Methodist Episcopal, and you're listening for subtle dysarthria, which is trouble with speech articulation due to muscle weakness. The next major component of the neurological exam is an examination of motor functioning, and you're looking for abnormal movements. So some of these include akinesia, which is a lack of spontaneous or voluntary movement, bradykinesia, which is a slowness of movement, athetosis, which is involuntary, slow, writhing movements, often involving hands, fingers, toes, and feet, chorea, which is sudden, unintended, and uncontrollable jerky movements of the arms, legs, and facial muscles, often described as somewhat of a dance, and bulismus, which is repetitive but constantly varying large amplitude involuntary movements of the proximal, or closer to the torso, parts of the limbs. And it's worth looking up videos of these different movement abnormalities to get a good understanding of what they look like before patients come in. Additionally, for motor functioning, you'll assess abnormalities in muscle tone. So muscle tone is how stiff or supple our muscles are at any given time. So to do this, patients are asked to move each limb across different joints to evaluate resistance or overall rigidity. And there's a general scoring criteria, with 0 being no visible muscle contraction, 1 being a flicker or trace of a muscle contraction, 2 being active movement when gravity is removed, 3 being active movement against gravity, but not when someone is pressuring against the limb they're trying to move, and 4 with active movement against gravity with light resistance, and 5 being normal strength against gravity and full resistance. And testing different muscle groups can help localize what specific nerves or tracts are disrupted. So some important neuroanatomy to understand when it comes to voluntary movement. We have upper motor neurons, which are projections from the cortex to the spinal cord along both the cortical spinal and pyramidal tracts. And if you note about just below halfway of this picture, there's an arrow that points to the desiccation of pyramids. And that's where the pyramidal tract crosses the sagittal midline occurring in the medulla. That's why your right hand is controlled by your left brain and your left hand is controlled by the right side of your brain. When there's dysfunction in these upper motor neurons, it can cause what's called hyperreflexia, where you have an overactive or overly responsive bodily reflex. And it can also just increase general muscle tone. Individuals with upper motor neuron disruption can also experience what's called pronation drift. So if you extend both hands in front of you and close your eyes, one of your arms may twist to a palm down position and your arm would come in towards the midline of your body. And that would indicate upper motor neuron dysfunction. There's also lower motor neurons, and these are motor nerve projections from the brainstem and spinal cord to skeletal muscles. And damage to these lower motor neurons can cause atrophy, what are called fasciculations, which is spontaneous involuntary muscle contraction and relaxation, or a muscle twitch, or hyporeflexia, which is a decreased or absent reflex response. Another component of the neurological exam is an examination of reflexes. In particular, deep tendon reflexes are evaluated with a single brisk tap from a reflex hammer on the skin of the tendon, and you're looking for either hyper or hyporeflexia to help identify whether there's upper motor neuron damage or lower motor neuron dysfunction. And there's a variety of grading scales to assess these deep tendon reflex responses. One common grading scale includes 0 being no response, which is abnormal, 1+ being a slight response, which may or may not be abnormal, 2+ being a brisk response, which is considered normal, 3+ being a very brisk response, which may or may not be normal, and 4+, which means that the tap elicits a clonus, which is a repetitive reflex, and that's considered abnormal. And medical staff are also looking for asymmetries or discrepancies between arms and legs that can also indicate dysfunction along our motor systems. So there's a variety of things, including clonus, spasticity, and hyperactive deep tendon reflexes that indicate dysfunction of cortical spinal tracts. Another way of testing cortical spinal functioning is called the Babinski sign. So you take a probe and you scrape along the lateral or outside surface of the bottom of someone's foot from the heel toward the big toe. And a positive sign is when the big toe goes up and the other toes fan out. So that, in an adult, would indicate dysfunction along the cortical spinal tract. It's important to note that in children under the age of 1, a positive Babinski response is normal. But as they mature and these tracts develop, they'll stop showing that positive sign, usually about when they're 1 year old. Another useful test is called the Wartenberg sign, and that's an involuntary abduction of the fifth or little finger. So you'll notice that the little finger often deviates away from the other fingers on the hand. Another component of the neurological exam is evaluating sensory functioning, and this is usually assessed by evaluating sensory dermatomes, which are areas of skin in which sensory nerves derive from a single spinal nerve root. So if you look at the graphic to the right, you'll see that different parts of our skin are innervated by specific nerves coming out of specific parts of our spinal column. So you can see, for example, the T1 nerve root covers much of our shoulders and the medial and lateral part of our arms. Assessing dermatomes can be useful for localizing lesions to specific nerves, nerve roots, spinal cord regions, and areas of the brainstem, as well as the thalamus and cortex. And these dermatomes will be tested using a light touch, using things like a cotton swab or just a light finger touch. They'll test for pain by poking with a sterile pin along the dermatome. They'll test someone's sensitivity to temperature, usually by placing a cold piece of metal against that part of the dermatome, as well as vibration by placing a vibrating tuning fork against the skin. They'll also test digital position by minimally moving someone's finger or toe and then asking the patient the direction of the movement. There's a few other important concepts when it comes to testing sensory functioning. One is stereognosis, which is the ability to identify objects by touch with just one hand. Another is graphesthesia, which is the ability to identify symbols, whether they be letters or numbers or other kinds of shapes that are drawn on the skin, as well as sensory extinction. This is a clinical phenomenon where, for example, if you poke one finger into their skin, they'll notice it. If you poke a second finger into a different part of their skin, they'll notice it. But if you poke both fingers at the same time into their skin, they won't notice that there's two fingers being poked. Or if you rapidly alternate between the fingers, they also won't notice that there's two fingers being poked into them. And sensory extinction can indicate contralateral parietal lobe dysfunction. So when there are sensory cortex lesions, people can have intact primary sensation with contralateral astereognosis as well as agraphesthesia. A neuropsychologist may test these types of functionings during an evaluation. The next important area of assessment during a neurological exam is an evaluation of gait. So there's a variety of neurological systems involved in both gait and coordination, including things like the cerebellum and basal ganglia. And common gait abnormalities that you're looking for include what's called a spastic gait, and this is characterized by circumduction or an arced motion of the leg swings, particularly on the affected side. So you're essentially swinging your leg around outside the other leg in a semicircular motion. And this is associated with spastic hemiparesis. So hemiparesis being weakness along one side of the body. There's also a scissored gait, which is characterized by a stiff gait where the legs cross in front of each other, and this has a high risk of causing falls. And this indicates cortical spinal dysfunction. Another type of gait is a steppage gait, which is characterized by what's called foot drop. So that's the inability or impaired ability to dorsiflex or raise your foot at the ankle due to muscular weakness or paralysis. So it tends to be hard for that person to lift their foot off the ground. As well as a Parkinsonian gait, which is characterized by short, shuffling steps, stoop posture, reduced arm swing, and difficulty starting or stopping their gait. And you'll see that most commonly in Parkinson's disease, but there are other conditions that present with a Parkinsonian gait, and that's associated with dysfunction of the basal ganglia. Finally, there's ataxic gait, which is characterized by an unsteady, wide-based gait and difficulty turning, and that's associated with dysfunction of the cerebellum. And you'll typically see this when someone is inebriated on alcohol. Alcohol has a very strong impact on our cerebellar functioning. Another aspect of the neurological exam is examination of coordination, and cerebellar dysfunction is a big contributor to abnormalities in coordination. Upper extremities, coordination is evaluated by having the patient touch their nose and then reach out and touch the examiner's finger over and over again. And what the examiner is looking for is dysmetria, which is a lack of coordinated movement, which is typified by overshooting or undershooting the intended position of the hand, arm, leg, or eye. So they'll reach out and they'll miss your finger, but then correct. They might come in short or reach too far. Another test of coordination is alternating hand movements, things like going from palm up to palm down quickly. And for this, when there's dysfunction, it's called dysdiadochonesia, and that's an impaired ability to perform rapid alternating movements. And the presence of either dysmetria or dysdiadochonesia indicates ipsilateral cerebellar dysfunction, so along the same side of the cerebellum. For lower extremity, that's evaluated by what's called a shin-heel test. The patient lies on their back or sits in a chair, and they have to move the heel of one leg along the shin of the opposite leg, and you'll test both sides. Other important signs to look for include Romberg sign, which is an unsteadiness when standing with people's feet close together and their eyes closed. And this unsteadiness usually occurs within seconds after they close their eyes. And it's thought to be due to the removal of visual input into truncal or proximal stability, forcing the individual to rely on just their proprioception and vestibular senses. Poor proprioception is associated with posterior column dysfunction. If they're showing instability with their eyes open, that suggests severe proprioceptive and vestibular dysfunction or some kind of midline cerebellar lesion. So if you look in the top right graphic, you'll see the highlighted part, that would be the midline of the cerebellum. The final component of a neurological exam is the mental status exam, and this is a brief global screening of brain functioning. The things that are being evaluated during a mental status exam are things like alertness. Are they falling asleep? Are they alert and aroused? Are they able to engage with the practitioner? Are they paying attention? Are they cooperating? Are they oriented to person, place, time, and situation? There will be brief screens related to memory, language, neglect, and praxis. So this can help indicate either limbic, left hemisphere, or right parietal lobe functioning. You'll evaluate their thought process, whether it's sequential or organized. Is the information they're providing logical and presented in a logical fashion? Are they speaking in very concrete terms, or are they able to consider things in a more abstract way? And this can be relevant for frontal lobe functioning. What's the content of their thought? Are they presenting with delusions, hallucinations, intense phobias, obsessions, and perseverations? Perseverations being getting stuck on a thought and being unable to move past it. What's their insight into their condition, and what's their judgment like? What's their mood? Are they euthymic, dysphoric, euphoric? Are they angry, anxious, apathetic? Or affect, which is how they display their emotional state. Does it look normal? Is it somewhat blunted? Is their affect highly exaggerated, flat, heightened? Are they being overly dramatic? Those kinds of things. Physicians may use both non-standardized methods as well as standardized normative screening tools to assess mental status. And neuropsychologists often use both non-standardized and standardized tools to screen for mental status as well. There are some limitations to the standardized screening tools, including that many aspects of cognition aren't very thoroughly evaluated on those tools. Remember, they're screening tools, so they're designed to be brief and limited. If you want a more thorough evaluation, you would need to refer to a neuropsychologist for a more thorough evaluation. Another limitation is that the screening tools are often not sensitive enough to identify subtle changes in cognitive functioning. So a normal score may not indicate actually intact cognitive abilities. It might just be that the instrument isn't sensitive enough to identify a modest level of decline. The next type of diagnostic tool we're going to discuss is structural neural imaging studies. The neurological exam continues to be a very useful tool for diagnosing and localizing lesions, and it was developed well before we had any kind of neuroimaging technology that didn't involve cutting open someone's head. Nowadays, neuroimaging allows us a more direct visualization and localization of structural abnormalities within the brain. And there's a variety of different techniques that have different utility and image resolution. The ones we're going to talk about include the conventional skull X-ray, computed tomography, magnetic resonance imaging, and there's a variety of MRI technologies including diffusion-weighted MRI, perfusion-weighted MRI, susceptibility-weighted imaging, diffusion tensor imaging, magnetic resonance spectroscopy, and magnetic resonance angiography. So we'll start with conventional skull X-ray, and it's used for a rapid examination of skull injuries or brain abnormalities. So you're looking for things like birth defects, infections, foreign bodies, pituitary tumors, and certain metabolic and endocrine disorders that can cause bone defects. One thing to note is that skull X-rays require exposure to a small amount of ionizing radiation. Building off of these conventional skull X-rays is computed tomography, or the CT or CAT scan, and this is a digital reconstruction of multiple narrow X-ray beams that's rotated around the head, and the absorption of the X-ray can vary based on the density of different tissues in the head. The image produced is monochromatic, with more dense tissue appearing brighter or hyperdense and less dense tissue appearing hypodense. There's also tissue that presents as isodense, which just means that it carries the same brightness as the tissues around it. So hyperdense tissues tend to be light colored and includes things like bone, freshly congealed blood, and other calcifications. Isodense tissue includes things like brain tissue and cerebral spinal fluid. And hypodense are dark colored features that include things like air and fat tissue. So these are various CT images, and you can look and see the bright white bone structures as well as the dark pockets indicating either nasal cavities or ventricular cavities, and that the brain tissue tends to be a relatively uniform looking color. So CT imaging tends to be more useful than conventional skull X-rays at detecting and characterizing gross abnormalities, so things like skull fractures, hemorrhages, mass effects, etc. And they're often the first choice when you're presenting at an acute setting. There are some limitations, so it tends to have a low resolution for brain tissue, so you don't get a good detailed picture of what someone's brain looks like. And it's not as effective for identifying changes in white matter, such as things like plaques related to multiple sclerosis or MS, or microvascular ischemic changes, and it can be hard to differentiate between tumors and other kinds of masses with just CT imaging. This can be enhanced by introducing what's called an intravenous contrast agent, and that can improve the resolution when it comes to things like brain tumors, arteriovenous malformations or AVMs, aneurysms, cerebral abscesses, chronic isodense hematomas, or even infarcts. There are some risks related to computed tomography. So because it uses X-rays, you're exposed to a small amount of ionizing radiation, and some individuals may experience allergic reactions to the contrast agents. The next imaging technology we're going to discuss is magnetic resonance imaging. Forgive me for the simplified explanation. I am not a physicist or an MRI technician. A brief description of how MRIs work is that the patient is put into a strong magnetic field which helps align atoms within the body, particularly hydrogen atoms, and radio frequency pulses are used to manipulate the axis of spin of these hydrogen atoms. When the radio frequency pulses are stopped, the hydrogen atoms return to their original alignment within the magnetic field, and they emit an electrical signal that's detected by the scanner. And these electrical signals are reconstructed into an image with computer processing. Contrast between the different tissues is the result of the rate at which the excited atoms return to their original alignment. And the image produced varies based on the timings of measuring this electromagnetic process. So you can have a T1 weighted image that produces greater anatomical detail with reduced tissue contrast. And in these images, the cerebral spinal fluid appears dark. A T2 weighted image, which produces greater contrast than T1 images, And in these images, the cerebrospinal fluid appears bright, and this is useful for identifying lesions such as lacunar infarcts or white matter lesions. And another process is called fluid attenuation inversion recovery, or FLAIR, and that provides even greater contrast compared to T2 weighted images. So if you look at the graphic on the top, you can see examples of the T1 and T2 weighted images. And they're not the same slice, but you can see the difference in contrast that occurs in the T1 image versus the T2 image. And then in the bottom right, that's a FLAIR image that's provided. You can further enhance contrast by injecting with paramagnetic contrast agents such as gadolinium. And that can help to identify blood-brain barrier and cerebral blood flow issues, infections, and inflammation. So MRI produces high-resolution anatomical images of the brain with clear visualization of both gray and white matter. And this high resolution allows the ability to detect low contrast or small brain lesions like arterial venous malformations, MS-related lesions, and low-grade astrocytomas. Additionally, MRI does not expose people to ionizing radiation, which allows for its repeated use on adults and children. Overall, there's minimal risks. There may be some noise and or claustrophobia-related discomfort entering into the magnetic field. And it should be noted that movement during imaging can produce various kinds of artifacts. Additionally, MRI may be contraindicated for individuals with implanted devices or residual metal fragments embedded in their bodies, but many devices nowadays are being developed to be MRI safe. So a type of MRI is diffusion-weighted MRI, and this is a method using the diffusion of water molecules to demonstrate contrast for the image. And this can be useful for detecting and differentiating edema or fluid accumulation that causes swelling related to stroke, as well as help differentiate acute versus chronic stroke injuries. There's two types of edema that are worth being aware of. One is cytotoxic edema, which is typically stroke-related, and the other is vasogenic edema, which is related to other types of cerebral lesions or events. Diffusion-weighted imaging can also be useful for determining whether to use thrombolytic agents, which are blood clot-breaking drugs, and it's very sensitive to microstructural changes within the brain. So you can typically detect white matter changes with diffusion-weighted imaging before conventional imaging. Another MRI process is perfusion-weighted imaging. This is often used concurrently with diffusion-weighted imaging, and this helps enhance our understanding of the cerebral vascular response within the brain. So with this imaging technique, you're looking at various hemodynamic parameters, including cerebral blood volume, cerebral blood flow, the mean transit time, and the time to peak tissue response. And this can be useful for identifying various brain tumors which have unusual diffusion rates due to the mass effect, or they show strange metabolism, or they'll cause pathological leakage across the blood-brain barrier, which are all detected by this perfusion-weighted imaging. Susceptibility-weighted imaging is another type of MRI process, and this detects magnetic susceptibility differences, or how much of the material has become magnetized between various tissues. It's sensitive to very small amounts of blood products and calcium, which are things that may not be detectable by other MRI sequences. So given this sensitivity, it can be used to detect microhemorrhages and other small lesions secondary to subtle traumatic brain injuries, or cerebral amyloid angiopathy. Another MRI sequence is diffusion tensor imaging, and this has become more popular in recent years. And this is helpful for examining white matter integrity. So this detects directional movement of water molecules, which can differ depending on the orientation of neuronal fibers and white matter tracts. And the main characteristic that's being evaluated is anisotropy. So what's found is a higher fractional anisotropy in densely myelinated and organized brain areas, so things like the corpus callosum or pyramidal tracts, which essentially just means that the diffusion of water tends to move along those tracts. You'll find lower fractional anisotropy in less myelinated and organized brain areas. Injury and edema can also lower fractional anisotropy values. There's ongoing research utilizing this technology, including the Human Connectome project. And you can look at the graphics on the right to see generally what these images consist of. And this technique tends to produce very striking images of these white matter tracks. The next technique we're going to talk about is magnetic resonance spectroscopy, or MRS. And this is an MRI sequence to localize and detect various biomarkers. So this can represent either endogenous biochemicals or exogenous ones. And it includes things like creatine, which is involved in APT production, N-acetyl-aspartate, which is a brain metabolite of neurons and glia, glutamate, which is a primary neurotransmitter, choline, which is a precursor molecule for acetylcholine production, and others. And it can be helpful to detect diseases characterized by neuronal loss, things like Alzheimer's disease, or other diseases characterized by demyelination, such as MS. Finally, the last structural imaging technique we're going to discuss is magnetic resonance angiography, or MRA. And this is an MRI method to generate images of blood vessels, particularly arteries. And this helps to identify things like stenosis, occlusion, and aneurysm. In comparison with other kinds of conventional angiographic techniques, things like catheter angiography or CT angiography, MRA is non-invasive and does not require exposure to ionizing radiation. That said, there are some notable disadvantages that prevent MRA from overtaking these conventional techniques as the gold standard. One major disadvantage is that MRA tends to have a lower spatial resolution compared to these other techniques, and it's best if the vessel is larger than 3 millimeters. It's also less sensitive to vessels with slower blood flow, and it's a much longer procedure than a CT angiography. The next diagnostic tools we're going to discuss are functional neuroimaging studies. So these are methods and techniques which measure changes in corollaries of brain activity. So things like blood flow, glucose uptake, or oxygenation over time. And these changes can be measured in both rested or activated states, with activated meaning that they're engaged in some kind of cognitive or motor task, and rested meaning that there's no intentional stimulation occurring at the time of imaging. Just be aware that there's various brain networks that continue to be active even during the rested states. So the first functional imaging study that we're going to discuss is single photon emission computed tomography, or SPECT imaging. And this detects regional cerebral blood flow through the use of tracer radioisotopes added to blood. So these tracers are absorbed by glia and remain in higher concentration in more active brain areas. A computerized image is generated based off of the release of these radioactive particles. And certain tracers are specific to certain neuropathologies, including things like beta amyloid and tau pathology. SPECT technology tends to be more accessible, and the radio tracers are more stable than other types of functional neuroimaging, which makes it somewhat cheaper and more available than other types of functional neuroimaging. The next functional neuroimaging technique we're going to discuss is positron emission tomography, or PET scans. And these examine brain metabolic activity via glucose utilization with radioisotopes. And these tend to provide greater spatial resolution than SPECT imaging. And it can be useful for diagnosis between dementias. So for example, Alzheimer's disease tends to present with bilateral hypo, or lower metabolism, in anterior and mesial temporal lobe areas and posterior temporoparietal cortices. Additionally, it can be used to image beta amyloid plaques, which can be useful for diagnosis but doesn't actually measure the functional impact of the pathology. So that pattern with Alzheimer's disease can contrast with frontotemporal dementia, which shows frontal and anterior temporal hypometabolism. And PET imaging can be combined with CT or MRI, particularly when it comes to tumor characterization. So when reconstructing the PET image, the computer uses a color-coded pattern to show where there's low versus high glucose uptake in the brain. So the higher glucose uptake is indicated by red or yellow colors, whereas lower glucose uptake is indicated by blue or green colors. There are some limitations to PET imaging, predominantly that it's a much more costly procedure than SPECT, and it typically requires an on-site chemist and cyclotron to create the tracers that are used during the imaging. The next functional imaging technology we're going to discuss is functional magnetic resonance imaging, or fMRI, and this measures regional cerebral blood flow using oxygenation levels, which is the relative signal strength of oxyhemoglobin, or blood cells that are carrying oxygen, and deoxyhemoglobin, which are blood cells that aren't carrying oxygen. And this creates what's called the blood oxygen level dependent effect, or BOLD effect. Clinically, fMRI is often used for presurgical mapping for epilepsy and tumor resection surgeries. It's great because it doesn't require any kind of exogenous tracers, radioisotopes, or contrast agents, and it has a much higher resolution than SPECT and PET. The limitations typically revolve around applying research findings in a clinical setting. It can be difficult applying group findings to individual cases, and reliability hasn't been as good as we'd hoped when replicating these fMRI experiments. The next type of diagnostic studies we'll discuss is electrophysiological studies. So the first electrophysiological study we're going to discuss is the electroencephalogram, or EEG, and this monitors brain electrical activity, or voltage fluctuations, across the scalp. And these findings represent the sum of rhythmic activity of thousands of neurons through the skull. And this is primarily used to differentiate epileptic seizures from other types of events, things like non-epileptic seizures, fainting, or subcortical disorders. It can also be used for the diagnosis of coma and other specific neurological disorders like herpes encephalopathy, which shows repetitive, slow-wave complexes over temporal lobe areas that can be unilateral or bilateral, and it's in the context of having an acute cerebral disruption. EEG is used to determine brain death, as well as monitoring during anesthesia and monitoring for sleep studies. Quantitative EEG, or QEEG, is an application of digital signal analysis techniques to continuously monitor and quantify the wave frequencies. So for EEGs, the waveforms are classified based on the frequency, amplitude, and overall shape. And the most common waveforms are alpha waves, which are observed across someone's lifespan, but most common in adults, and typically manifest when someone's relaxed with their eyes closed. And you'll see it bilaterally in more posterior regions of the head. If there's anterior alpha activity, that can indicate drug use, anesthesia, or just having woken up from sleep. Beta waves are also observed across the lifespan, and they're dominant when someone's alert, anxious, or has their eyes open. These occur symmetrically, particularly in the frontal regions of the head. And beta wave activity can be enhanced by sedating drugs, things like barbiturates or benzodiazepines. And this is thought to be a way that our body's compensating for the sedation. Theta waves are observed in children and sleeping adults, and it's most common during drowsiness with transient occurrence during wakefulness. And delta waves are observed during sleep and is a dominant rhythm in infants. And that occurs more frontally in adults and posteriorly in children. And if you look at the graphic on the right, you'll also see gamma waves, but I'm not going to get into those. Diffuse disorders or metabolic disorders occur that affect the brain. You'll see a generalized distribution of the beta and theta activity. Another electrophysiological study is evoked potentials, and these measure EEG responses to various stimuli, whether they be visual, auditory, or somatosensory. For visual evoked potentials, you'll display a fixed visual pattern to each eye, and a prolonged latency can indicate dysfunction of the optic nerve, or ischemic disturbance, or demyelinating pathologies. Auditory evoked potentials are measured by administering repetitive clicks to each ear, and somatosensory evoked potentials are measured by administering mechanical or electrical stimulation on the skin. And this technique can be helpful for detecting and localizing lesions in the central nervous system, particularly those related to MS, AIDS, and neurosyphilis. And it can also be used to assess prognosis following central nervous system trauma or hypoxia, as well as assist in intraoperative monitoring. The next electrophysiological studies we'll discuss are electromyography, or EMG, and nerve conduction studies. So these involve recording electrical activity in specific muscles and peripheral nerves. For an EMG, the electrode is inserted into the muscle, and for a nerve conduction study, the electrodes are taped to skin. And this can be useful for identifying certain pathologies, things like traumatic denervation or spinal cord degeneration disorders. The final electrophysiological studies we're going to discuss are magnetoencephalography, or MEG studies, and magnetic source imaging studies. So similar to EEG, MEG detects minute magnetic fields generated by neuronal activities, which are voltage changes during action potentials. It has a reduced setup time compared to EEG because all the detectors are located in the helmet and you don't have to glue anything to the person's head. And it tends to have better spatial resolution compared to EEG. A major limitation is that it's not widely available and it's very expensive because it requires the construction of a specific facility to support its use. Magnetic source imaging is an integration and localization of MEG data onto an MRI image. The final diagnostic category we're going to discuss is invasive examination procedures. So the first one we're going to discuss is cerebral arteriography, and this is used to characterize arteriovenous malformations or AVMs, aneurysms, and sinus venous thrombosis. And it requires catheter insertion into either the femoral or brachial arteries, and that's threaded up into the carotid artery. Once that catheter is up into the carotid artery, then an iodine-based contrast is injected into the cerebral vasculature and a series of radiographs is taken. And this can help identify neovascularization of tumors, and it's employed during aneurysm coiling procedures. There are a few complications associated with cerebral arteriography. Notably, it can cause strokes, it can result in thrombosis or embolism formation, or individuals can have allergic reactions to the contrast agent. Another invasive procedure is WADA testing, or intracarotid sodium amobarbital procedure, and this involves injecting a barbiturate, usually sodium amobarbital, into cerebral vasculature by an angiographically guided catheter. So this is used to anesthetize the ipsilateral cerebral hemisphere, which allows you to better evaluate the functioning of the contralateral hemisphere. So during this process, you'll briefly test certain cognitive abilities, things like language, memory, voluntary movement, to help determine the capabilities of each hemisphere independently. And it's commonly used in pre-surgical evaluations for epilepsy, and it helps identify hemispheric dominance for language and potential postoperative cognitive losses. The next technique we're going to discuss is computed tomographic angiography, or CTA, and this is used to visualize arteries and veins, and it combines CT imaging with intravenous injection of radiocontrast, and this can produce high-resolution 3D renderings of vasculature and anatomy in about 5 to 10 seconds. And this can be used to evaluate cerebral vascular diseases, things like carotid stenosis, intra and extracranial arteriosclerosis, as well as aneurysms. And it tends to be less impacted by patient movement than things like MRA. One limitation is that it's less sensitive to small aneurysms, so aneurysms that are less than 3 millimeters. As well, it may not reveal plaque ulcerations or small vessel disease. The final technique we're going to discuss is the lumbar puncture, or the spinal tap. And this is used to obtain samples of cerebral spinal fluid and measure cerebral spinal fluid pressure and remove cerebral spinal fluid if necessary. So the samples are visually inspected and tested for blood or bacteria. Remember that there's a physical separation, which is the blood-brain barrier between our vascular systems that carry blood and our cerebral spinal fluid systems. The lumbar puncture is conducted by either having the patient lying or seated and inserting the needle below the spinal cord, usually at the L1 or L5 junction. And this helps to detect infections, inflammatory diseases, subarachnoid hemorrhages, intracranial pressure abnormalities, and other various biomarkers. So for example, you can look at tau levels in cerebral spinal fluid, and that can help you identify Alzheimer's disease, frontotemporal lobar dementia, or amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease. If you're looking for more information on these topics, once again, the Stuckey et al. Clinical Neuropsychology Study Guide and Board Review is a great book. Additionally, Neuroanatomy Through Clinical Cases by Hal Blumenfeld is very informative and contains lots of information related to cranial nerve injuries. If you want to learn more about the neurological exam and other components relevant to neurology, Neurology for the Non-Neurologist can be a helpful book. And if you want to go in depth into neurological practice, Adam and Victor's Principles of Neurology is another fantastic tome. For more information relating to neuroimaging in humans, Optibrix and Nakatani's Introduction to Human Neuroimaging is a great book. And if you want to learn more specifically about EEG interpretation, Tatum's Handbook of EEG Interpretation may be helpful for you. And for learning more about neuropsychological practice, the Little Black Book of Neuropsychology by Schoenfield and Scott, and the textbook of Clinical Neuropsychology by Morgan Ricker are both great books, as well as a pocket handbook for assessment by Parsons and Hamecki, as well as Lazak's Neuropsychological Assessment. If you want any additional study resources, be sure to go to brainaacn.org, where you can find written and oral exam study groups, mentorship opportunities, mock exams and sample questions, flashcards, and other book recommendations. This has been TLDR Neuropsychology. Be sure to like, subscribe, and comment below. Thanks for your time, and have a great day.